Good afternoon. I'm here to talk about Digistain. This is a novel reagent-free assay which has been assessed in initial study to assess its clinical performance in predicting the outcomes of women with hormone receptor-positive breast cancer. The aim is to evolve this assay into a test that might be used for making decision-making in the clinics in due course. So, as we all know, there are several risk scoring methods available by which we can make decisions around who requires adjuvant chemotherapy. These are generally genomic assays, 21 gene recurrence score. Mammoprint are two widely used. However, there are issues with these genomic assays, cost, turnaround time. Clearly, in many countries, patients have to pay for these assays, and often, particularly in economically developing countries, patients can't afford them. So, the development of a more cost-effective methodology would clearly be beneficial both to healthcare systems as well as to patients. Mid-infrared spectroscopy of formalin fixed tumour biopsy material can be used to determine a novel prognostic marker called the Digistain index. The Digistain index, or DI as we'll call it moving forward, reflects the level of aneuploidy within a tumour. As many of you know, aneuploidy is an established biomarker which has been demonstrated to have independent prognostic potential. However, it's very difficult to measure routinely. You need to use laser flow cytometry, which is clearly not readily available outside of research labs. We know that the DI univariately correlates with tumour grade. So this initial study was done to evaluate its performance, to see how it did for the first time in a set of patients. So this is the workflow for undertaking Digistain and to get the Digistain prognostic score. In essence, you take a tumour block, it's cut, it's deparaffinized, it's then assessed using infrared spectrometry. This produces a spectroscopic signature that essentially reflects the biology of the tumour, and then this is plugged into an algorithm and analysed to produce a risk score, and the patient's divided into either high or low risk. The study to assess the performance of the Digistain prognostic score was undertaken using the Nottingham City Hospital series. It's a well-characterised series, being published many times. There are 801 patients who were diagnosed between 1998 and 2006. All were aged 70 or younger, hormone receptor positive and HER2 negative with primary operable breast cancer. Up to 3 lymph nodes could be involved. All tumours were equal to or less than 5 centimetres. DCIS was excluded. All patients did not receive adjuvant chemotherapy, given either had an MPI score less than 3.4, or those patients who had an MPI score greater than 3.4 received only endocrine therapy. So this is a well-characterised series who received no adjuvant chemotherapy. So this is the methodology. In essence, 2 adjacent sections from the Nottingham tissue microarray were cut, 4 microns thick each. One was sectioned and H&E'd and used for grading of the Nottingham prognostic index, and the other one deparaffinized and subjected to the infrared spectrometry to generate the Digiscore index. This was done by 64 spectra being recorded and averaged out for each unstained section. The resulting average spectra then converted intra-unique absorption spectrum for each tissue, and this gave the digital risk score, which is then used to pass patients to low or high risk. The Digistain risk score is used is produced by a proprietary software, which is actually what makes this unique. So analysis, the Digistain risk score, or the DPS, was generated for each tissue sample using a multivariable proportional hazard model using the following covariates: patient age, lymph node status, grade, tumour size, and the IR absorption spectrum. This was used to define the continuous relationship between the DPS and clinical outcomes. Data were fitted by a time-varying piecemeal log hazard ratio model with all the covariables above. The classification, as I said before, is into low and high risk using the DPS. The cutoff was chosen based on a 10% risk of recurrence. As we know, this 10% cutoff has been used to develop and test other genomic assays such as MammaPrint. So that 10% cutoff was used to break patients down into either high or low risk. So these are the patient characteristics that are well published previously: 801 patients, median age of 53. The median tumour size was 1.6 centimetres. The vast majority were ductal carcinoma, as one would expect, either grade 1 or 2. And again, the vast majority were lymph node negative, around 32% being lymph node positive. And again, if we look at the menopausal status, 30% were less than 50, and 37% were greater than 60, and this defines the pre- and postmenopausal groups. So again, just on the Nottingham Prognostic Index, most had an MPI which is good or moderate, a small portion were poor prognostic index, and the vast majority remain alive and well, with 20% having suffered a recurrence, and we've got a very good follow-up here of 12.7 years. So in essence, this group represents a low-risk population which is needed to accurately determine if anybody else can be spared needs chemotherapy. So just on Digistain index and pleomorphism, aneuploidy is a negative prognostic factor in several tumour types, including breast. As I've alluded to before, measuring aneuploidy is very difficult outside of research labs. However, as a surrogate for aneuploidy, one can use pleomorphism. Pleomorphism is recorded when tumours are graded, and as you can see here, the vast majority in the Nottingham series had a grading of 3 with regard to the pleomorphism. The Digistain index showed a borderline statistically significant relationship with pleomorphism, with a p-value of 0.053. So let's move on to the data. So when we look at the Cox proportional hazard ratio model for estimating the contributions of variables to predicted outcomes, we can see here that the Digistain index contributes a lot of information to the overall survival, with a hazard ratio of 4.49 and a p-value of 0.039, and it outperforms the other variables that predict outcomes. Again, if we look at recurrence-free survival, again, Digistain index performs very well compared to the other prognostic markers or covariables, with a hazard ratio of 4.41, and again with a significant p-value of 0.013. So in summary, the Digistain index significantly associated with both OS and RFS. The 9% continentals, while wide, were seen with other prognostic markers such as the mammoprint, and as can be seen, it performs very well compared to other covariables which are known to be predictive of prognosis. So what's the accuracy of DPS for predicting DPS for prediction of risk score at 5 and 10-year clinical outcomes? So here we've got RFS, recurrence, and overall survival. The key thing to focus on here is the negative predictive value, the NPV, and for this, this is over 97% at 5 years, and at least 90% or over at 10 years for all the outcomes. So again, shows you that in essence that the DPS is very good at predicting outcomes in this group by classifying women into a low or high risk group based on the DI. And typically for the genomic assays, they ran at AUCs around 0.75. So again, Digistain here is performing very well in comparison and is comparable to those in their initial development. Again, just to summarise, to identify low-risk patients, a high MPV using a 10% risk cutoff is needed. The MPV was high with the Digistain prognostic index, greater than 9% at 10 years. The values are similar to those reported for other genomic assays such as mammoprint. Again, let's look at the Kaplan-Meier curves. For the outcomes, again, these are the patients classified into high and low risk based on the Digistain index. And as you can see, the patients who have a who are classified as high risk based on the DI have a poor outcome, and this is significant for all three readouts of outcome: recurrence-free survival, recurrence and overall survival, as you can see there at the bottom of each of the curves. So again, the hazard ratios for DPS, to summarise, was significant for low versus high risk for all the three clinical outcomes. So let's go into some subgroup analyses. Let's first look at lymph node status. As I said previously, about 30% were lymph node positive. As you can see, the detailed breakdown of their tumour type, grading, pleomorphism, and the MPI is listed. As you can see, the patients who are lymph node positive have a worse MPI compared to those lymph node negative. Again, if we look at the accuracy of DPS for predicting for prediction of risk scoring for 5 and 10-year clinical outcomes by lymph node status, you can see that DPS performs very well both the high in the lymph node negative and in the lymph node positive, and you can see that the MPV both at 5 and 10 years is over 98% or more at 5 years, and over 90% for the lymph node negatives at 10 years, and slightly lower for the lymph node positives at 10 years, but still performing very well in this initial group of patients. Again, the Kaplan-Meiers for lymph node negative patients first. Again, as you can see, for the low versus high, the curves come apart, so therefore the DI does identify two separate groups of patients with different outcomes. As you can see, the high-risk patients do worse. It's statistically significant for the recurrence-free survival, and recurrence doesn't quite meet significance for the overall survival. again, this shows you that the Digistain index is able to separate patients into two groups, which predicts outcome. Again, let's just turn to age and menopausal status. So here we're just looking at women who are less than 50 and premenopausal, and those over 60 and postmenopausal. So two very clear groups. They're roughly equal numbers in each group, and the characteristics are listed here. So let's turn first to the accuracy of DPS for prediction of risk scoring for the 5 and 10-year clinical outcomes for age and menopausal status. And again here the take-home message is that the DPS performance was high in the pre- and post-menopausal patients, as shown by the high MPV in both groups, both at 5 and 10 years. And again, if we turn to the Kaplan-Meier curves, again, as you can see here, both for recurrence-free survival, recurrence and overall survival, the hazard ratios for DPS were significant for low versus high risk classification for all three outcomes, and all were statistically significant. Again, reinforcing the measure that the DI can separate patients into two distinct groups and predict their outcomes based on this. Again, similarly for the postmenopausal, the hazard ratios for DPS were significant for the low versus high risk classification for all the three outcomes measured, and again statistically significant. So just to conclude, so the Digistain index is derived from using infrared spectroscopy. It doesn't require any special material apart from the spectrometer to measure this. It's shown high accuracy and predictive performance in hormone receptor, hormone negative primary operable breast cancer with up to 3 lymph nodes involved. The Digistain was able to classify patients as low or high risk with similar accuracy and predictive performance as that reported for some of the other stratification tools available. The ability to provide low-cost, rapid and widely accessible prognostic testing indicates that DPS has the potential for significant clinical utility. You can see that this would open up much more readily accessible risk assessment of hormone receptor, hormone negative tumours than currently available, and doesn't need the tissue to be sent away to be analysed, and is easy to perform using only the paraffin-embedded block that is routinely derived during pathology. On that note, I'll just say thank you for listening.